Good evening, everybody. I'm Dr. Sayeda Rukshida. I have the honor of being the Honorary General Secretary of Indian Association of Biological Psychiatry, and I'm very pleased to welcome all of you to the first Friday CME series organized by IABP. We've done a lot of sessions in the series already, and as we know by now, it's a curated, open access educational series supported by unrestricted grant from our sponsors. And we have lovely speakers and wonderful chairs and expert commentators. And we have a good participation with a robust question and answer session at the end as well. With this, it's my pleasure and an honor to welcome the president of IABP, Dr. UC Garg, to please share with us, welcome us, and give us a few welcoming remarks. Dr. Garg, sir.
Thank you, Dr. Rukshida. Good evening, everybody. Good evening, Dr. Gautam Saha.
Good evening, sir. Good evening.
At the outset, let me first welcome all our esteemed participants, learned speaker, Dr. Kaustav Chakravarti, expert commentator, Dr. Supriya Hegde-Aru, our chairpersons, Dr. Professor Smita Deshpande, Professor Sudhir Bhave. If we go back about 40 years, we remember that at that time it was not very much difficult to treat the patients of depression, because we were treating patients of depression with their symptomatology mostly. And although at that time we were having very few molecules, especially tricyclic antidepressant, imipramine or amitriptyline, very rarely we were able to see enafrenil imported from abroad or MAO inhibitors. But we were able to treat depression very well. Depression with psychomotor retardation, we were able to treat. Depression with psychomotor agitation, we were able to treat. Psychotic depression, we were able to treat, because as soon as we give the antidepressant and we were not able to see the results, we started giving ECT, and it was the sure treatment for depression. So at that time, we were not seeing many cases of refractory depression. But nowadays, it is a routine in our practice that we see delayed response or refractory depression in our clinics. Although we are having a number of molecules in our basket to treat these patients, but sometimes we are not able to find out the right molecule for a right person, a right patient for a right patient of the depression. When we talk about the precision medicine, I think this is the right time to think about the subgroups of the depression, where we can divide depression in different groups on the basis of phenotyping or genotyping, and where we are able to give a specific molecule to treat that subgroup of the depression. I think the speaker will deal with such type of issues in his lecture. Before I end, I would like to congratulate our organizers, especially Dr. Rukshida Saida, Secretary General of Indian Association of Biological Psychiatry, CME Chairperson Dr. G. Prasad Rao, CME Committee Convener Dr. Nitin Gupta, and Joint Secretary cum Coordinator Dr. Majid. With these words, I express my sincere congratulations and the best wishes for the CME. Thank you all.
Thank you so much, Dr. Garg. That was IABP President Dr. UC Garg with his welcoming comments, and he's always very supportive, very encouraging, and very appreciative of everyone. So that validates us and it makes us do more and better. With that, it's a proud privilege to invite our chairs today. Just as we were talking before we just started the session today, we realized that, me and both the chairs are Maharashtrians. So it's doubly an honor for me to invite our very own Dr. Smita Deshpande. Ma'am, as we know, everybody knows her. She's highly skilled and very motivated, has her strength steeped in research and education. And recently she has crossed a new milestone in her life and moved to Bangalore and joined St. John's and as a research and encouraging research there as well. Dr. Smita Deshpande, we are very honored, ma'am, that you have agreed to chair the session today in spite of your busy schedule, in spite of, it just speaks about your commitment to science and commitment to IABP. Thank you so much for being here, ma'am. She's traveling right now, but even then, her enthusiasm knows no bound. Thank you so much, ma'am. And we also
Thank you.
Great.
Thank you for inviting me.
Ma'am, it's only with your encouragement and guidance that we are here today. So thank you so much for joining. We also have with us today Dr. Sudhir Bhave. He's a senior psychiatrist from Nagpur. I think IPS at large and West Zone in particular, we all admire him and revere him for all his hard work over decades and of his service to mental health and psychiatry in particular. Sir is a senior psychiatrist from Nagpur, like I said, and he's also head of department currently of NKP Savle Medical Institute at Nagpur. He's loved by everybody. His sessions when he's talking are never missed by anybody. And recently, one of his sessions on how to be a good, what makes a good psychiatrist is something that I think all of us should go back into archives and have a look at again. Thank you so much, sir, for accepting our invitation to chair the session. And I'm sure between you and Dr. Smita, ma'am, we're going to have a feast of academics today and a wonderful session. So it's please take over from here. Thank you so much again.
Yeah, thank you so much, Ruchida. Me and Dr. Smita both thank you profusely for honoring us by letting us be a part of this today's program. I'm sure that with the wonderful topic of resistant depression, which is something that keeps on haunting all of us clinically almost on a daily basis, I think we all are going to learn much. The speaker for today is Dr. Kaustubh Chakravarty. I'll briefly introduce him. Kaustubh happens to be the Associate Professor and Head, Department of Psychiatry, College of Medicine, and JNM Hospital, Kalyani in West Bengal. His present affiliations are, he is the convener of IPS Research, Education and Training Foundation Subcommittee. He is the Honorary Secretary of IPS West Bengal Branch. He is a Nodal Officer of DMSP Nadia. Kaustubh is a recipient of many awards like Sharda Menon Gold Medal in DNB, Fellowship of Japanese Society of Psychiatry and Neurology in the year 2011. I think he's the only person I have heard who has this fellowship from Japan. Dr. R.B. Davis Oration Award, has multiple publications, has contributed to 10 book chapters, has 24 papers in international journals and 36 papers in national journals. So I think I might say that in this relatively brief period of time, he has many accolades to his credit. And I'm certain that what he's going to speak for the next half an hour would be an ample testimony to his academic and learning skills. So may we have Dr. Kaustubh Chakravarty speak on rational psychopharmacological interventions in refractory depression. Over to you, Kaustubh.
Thank you. I think Ruchida madam was trying to say something. Yeah. Okay. So give me a minute to share my screen. Is it visible to everyone?
Yes.
Yeah.
Yes, yes,
Yes, sir, it is visible.
it is visible.
Yeah, yeah.
Yes, sir, it is visible.
It's okay, no?
Yeah, sure. It's visible.
Yeah.
Sure.
Okay.
Okay. Yeah. So first of all, I would like to thank Dr. Rukshida Saida for inviting me for this academic session. This is my first session with Indian Association of Biological Psychiatry. I would like to thank all the office bearers of Indian Association of Biological Psychiatry, including Dr. U.C. Garg and the chairpersons, Dr. Bhave sir and Dr. Deshpande ma'am. I also like to thank expert commentator, Dr. Supriya madam. Now, when I was given this topic, rational psychopharmacological interventions in refractory depression, I went through literature a lot. I tried to read a bit also the textbooks, the Stahl's psychopharmacology. It is always good to brush up your knowledge regarding psychopharmacology every time you come across such topic. And when we talk about rational, it is about evidence-based medicine that most of us should practice in our day-to-day clinical work. However, at times we need to deviate from that also, and all the time it is not the fault of ours. Like Dr. Garg has said, that the refractory depression, say 30-40 years back, there was not so much of refractory depression. I born that 42 years ago, so I can't comment upon that. But definitely nowadays in our clinical practice, every now and then we come across such patients who are, if not refractory, are probably poor responder to antidepressant treatment and need combination of antidepressants or need augmentation with some of the other agents. With this brief comment, I'd like to start my presentation. I have no conflict of interest, and I am not here to endorse any pharmaceutical agent. I have also a disclaimer that I have no original research work in the field of biological psychiatry, and what I will be citing today or presenting today has been taken from others' work or several other sources. So that is my disclaimer. So when we talk about treatment-resistant depression, before we label a person as treatment-resistant depression, because it is a very highly loaded word, one should ascertain that we have made a correct diagnosis. That is the requirement all the time, and the antidepressant that we have prescribed has been selected according to the diagnosis specifier that again Dr. Garg has alluded to in his introductory speech. We need to ascertain that patient has taken the adequate treatment for an adequate duration of time, which is usually 6 to 8 weeks or 6 to 12 weeks, which has been followed in the research protocols, and dosage which is up to 2/3 of the manufacturer's maximum recommended doses if it is tolerated by the patient. So these two criteria should be met, and patient should be assessed for medical and psychiatric comorbidity. We very well know that particularly the personality disorders, which are often comorbid with mood disorders, particularly depression, and comorbidity of anxiety disorders, often make a person a poor responder to antidepressant therapy. Also, medical conditions, particularly old age medical conditions like Parkinson, like small vessel disease of brain, the periventricular hyperintensity is if present, then they poorly respond to an antidepressant therapy. So after excluding this condition, individuals who are still non-responder or partial responder to antidepressant are defined as suffering from treatment-resistant depression. And it is also a very well-known fact that they are associated with a lack of efficacy feelings, suicidal risks, poor prognosis, impairment in work, social and family life. They have a poor physical health and increased healthcare utilization. So these are the consequences of having a treatment refractory depression. Now, when we search for a univocal accepted definition of TRD, it is not available, but the expert consensus is that failure of 2 or more adequate trials of antidepressant which are just mentioned in my previous slide, which fails in causing remission, might be an effective description of TRD. And there has been refocusing on TRD classification and prediction by using machine learning these days. We all know that artificial intelligence is now being increasingly used for psychiatric disorders for diagnosis, treatment, and monitoring. So TRD is considered a common clinical condition which is often associated with suicidal ideation and characterized by severe functional impairment lifetime. Now, when we look at the common trajectory of depression by nature is a recurrent illness. And with each episode, they tend to be longer, they tend to be more severe, and the inter-episodic euthymic period tend to get shorter. So this diagram beautifully depicts this natural course of depressive disorder in a person. Now, this is a very interesting perspective of depression. We all know that depression, like any other chronic diseases, be it a psychiatric disorder or be it any other non-communicable diseases, is multifactorial and polygenetic. So when we talk about the symptom expression of depression, it escalates from the lower level to the higher level. It starts with gene and signaling cascades, which results in synthesis of proteins, particular proteins, and then which translates into neurotransmitters. Cells are involved. There are various neurocircuit circuit in brains which are involved in emotional expression, emotional control, information processing. Local cell circuits are involved. There are certain brain areas, neural networks, which can be picked up by fMRI studies, and ultimately the behavior is expressed. So there is genetics, which we call genotyping. There is phenotyping, and ultimately we have the disorder. So this complex biological system emerges from the integration of events occurring across this hierarchical biological scale. So one can only speculate on mechanism underlying causal links between those opposite ends, that is the syndrome and the genes. We can only speculate. And when we talk about treatment-resistant depression, it can emanate from any of this these levels of biological system. It can be resistant at the level of genes. It can be resistance at the level of transcription factors. It can be resistance at the level of receptors, so forth and so on. So this is a brief we will talk in brief about the corticolimbic circuitry that is implicated in mood regulation and depression. This is well known to all of us, but for the PG students who might be watching this presentation, it will be just brushing their already existing knowledge. So there are circuits in brain, particularly the limbic circuitry, which involves the prefrontal cortex, dorsolateral prefrontal cortex, as well as the ventromedial prefrontal cortex, the hippocampus, hypothalamus, nucleus accumbens, and amygdala. So these are the main areas which are involved in emotional processing and might be involved in the expression of depressive symptoms. So this hippocampus, ventral hippocampus, has extensive connection to different areas of brain which modulate the emotional behavior, particularly hypothalamus, which is associated with innate fear and stress responses, amygdala, which is associated with learned fear, nucleus accumbens, again the motivation and reward system, bed nucleus of star terminalis, it is associated with anxiety symptoms and stress, the septum pellucidum, stress and reward, and prefrontal cortex, the spatial working memory, anxiety, and cognitive flexibility. So this is well known to all of us and all the PG students, but it is always nice to look at these things when we begin to talk about affective disorders. These are the receptors which are involved in antidepressant response. I will not go into the details of how the receptor works and what are the projections, neural projections that are involved in antidepressant therapy. But the in the serotonin system, these receptors are very much important, particularly the 5-HT1A autoreceptors at the somatodendric end on the synapse, 5-HT2A, 2C, also 5-HT1B, 1D, 5-HT7 for new molecule vortioxetine. 5-HT7 is also important, and the serotonin transporter. For norepinephrine, alpha-1, alpha-2, for dopamine, D1, D2, and dopamine transporter, histamine, melatonin, opioid, acetylcholine, GABA, glutamate. Almost all the neurotransmitters are involved in the mechanism of antidepressants. So it has been found that almost 20 to 30, some research have found the tune of 46% of patients with MDD fail to respond to antidepressant treatment. And approximately half of the patients who do not respond to first antidepressant will not respond to a second agent. And most of these data come from the seminal study, which I will come later on. And depression accounts for almost 11% of disability worldwide, and depression, if left untreated or undertreated, can result in lost work days. And lifetime suicidal risks for untreated depression can be as high as 30%. So these are the risks of having a treatment-resistant depression or undertreated or untreated depression. So what are the common residual symptoms in non-remitters? Particularly, as we are all clinicians, we are very, very well acknowledged that it is the sense of the anhedonia. Anhedonia is one of the most common residual symptoms, followed by lack of concentration, interest, fatigue and somatic pain symptoms, and insomnia. These are the most common residual symptoms which a patient complains in our clinic, and these residual symptoms predicts future recurrence of depressive episode, and subsyndromal chronic depression persists. So this is the Canadian expert consensus, which found some risk factors for developing TRD. This article has just been published last year, and they have found that frequent and recurrent depressive episodes have the highest predictability of predicting TRD, followed by symptom severity of the current episode, longer duration of illness, current psychosocial stressors. These are well known to all of us, but probably for the first time they have been listed and they have been published in an article. Number of lifetime episode, bipolarity features, current psychosocial stressors, stressful life events or trauma, comorbidities, which I have already alluded to, personality issues, anxiety, psychotic features, and treatment factors like the number of previous antidepressant trial, how much and how many augmenting agents he has received in the past, failed psychotherapy trials. So these all predict the development of treatment resistance in a particular patient. Now, there are genetics involved in depression, like I have already told in my previous slide, that it will not be far away when we will have our whole genome uploaded in our electronic medical database, and there are numerous candidate genes which have been identified, and there is a term called epistasis in genetics, in which if two or more genes, mutated genes, if they are carried forward, and they can predict the risks of developing a particular disease. So for depression, genes have been identified which if carried forward together can result in poor response to antidepressants. These can involve serotonin transporter, 5-HT2C receptor genes, dopamine receptors, catechol-methyl transferase enzyme genes, and methylene tetrahydrofolate reductase enzymes, which all are related to monoamine synthesis and monoamine neurotransmitter actions. Now, when we come across a patient with treatment-resistant depression, the first and foremost, we need to reassess our diagnosis and determine if primary psychiatric disorder versus a general medical condition like the hypothyroidism, anemia, which are most commonly associated in female patients. So we need to correct those things. If it is a primary psychiatric disorder, we need to consider treatment based on the subtype or specifier of depression. It is very important. And if there is psychiatric comorbidity, like a dual diagnosis patient, if they have comorbid substance use, that also need to be addressed. OC symptoms, if patients have OC symptoms, they also have poor response to antidepressant therapy. PTSD symptoms, again, need to be addressed. Adherence, that this is a big issue with our patients. It has been seen that almost 1/3 of the patients who come to a clinic do not fill their first month of prescription. And we also need to assess whether the patient has cognitive problems, particularly in the elderly population. Cost of the medicines, family support system, these all need to be assessed, and we can take help of the psychiatric social worker in that respect. We also need to consider the side effects of the antidepressants, whether the patient is dropping out or discontinuing the antidepressant because of that only. We also need to consider the pharmacokinetics, drug-drug interaction, rapid and fast metabolizers, smokers. These are all well known to us, but again, it is good to emphasize those things again and again. We need to confirm the correct dosage and duration of the medication trial also. So once we do all these things, then we need to optimize the dose if there is partial response. And I have already told that it has to be 2/3 of the manufacturer's dose recommendation. We need to at times lengthen the therapy if there are constraints where we can augment or combine the medications. We can substitute the medications. So we will come to these things later on also. We can switch the medication, we can augment, we can combine. We can use ECT. ECT is a very good option, but I can talk in terms of my experience in West Bengal. There are very few centers where modified ECT is being practiced, and we are handicapped by that deficiency. There is transcranial magnetic stimulation these days, VNS, DNS, direct brain stimulation. Psychotherapy is definitely one of the options, sleep deprivations, and physical activities and meditations also to some extent. Now, these are the few strategies that we all utilize in our day-to-day practice, the optimization, augmentation, switching, and combination. Now, optimization should be considered before referral to a higher level of care is made. Optimization generally consists of increasing the medication dose. Like if I am using 150 milligram of venlafaxine, we need to increase it to 225 or 300 milligram, which is the maximum recommended dose of venlafaxine for a duration of 6 to 12 weeks. Through potentially involving doses generally considered supratherapeutic, particularly for users who have required usually high medication doses in the past and have demonstrated good tolerability and partial response. Here I have a word of cautions that although very few of us at sometimes use supratherapeutic doses, which is usually not advised because that is not supported by medical literature, and there is no evidence based for that. So it is always good to keep yourself within the recommended therapeutic dose. You can use the doses at the higher levels, but never use those doses which are not recommended by the manufacturer or in the literature. So that is a word of caution. Augmentation and the addition of a non-antidepressant medication to an adequate dose of tolerated antidepressant is the logical next strategy. And this strategy is typically employed when a patient experiences at least partial response. So it is always best to add augmenting agent for a partial responder. And there are many augmenting agents, which I will come later on. These are some augmenting agents and their putative mechanism of action. Mood stabilizer, lithium is one such agent which works on the phosphatidylinositol pathway. There are SGAs like aripiprazole, quetiapine, olanzapine, and they works on the 5-HT1A, 2A, and D2 receptors. Thyroid, it binds to the thyroid ligand in the nucleus and have been found to be effective in the treatment of TRD. There are anticonvulsants like lamotrigine, valproate, and there is buspirone, which is used in combination with SSRIs or SNRIs, and it is a 5-HT partial agonist. Switching following monotherapy failure, the efficacy of switching medications versus augmentation appears comparable. So there is not much to choose between those two, and switching is particularly appealing in the setting of poor tolerability of an initial antidepressant. Little evidence exists to guide the clinician's decision to switch. Now, combination therapy refers to use of 2 or more antidepressants, typically from 2 different mechanistic classes. The aim is to stimulate 2 or 3 monoamine system at the same go. Combination strategies offer less risk of discontinuation symptoms compared with cross titration during switch, and increase the probability of positive antidepressant effects through drug synergism. There is a growing chorus for combos from beginning. There is a group of people who are suggesting that from the beginning we should start combination antidepressant like we do for HIV therapy, like we do for hypertensive treatment, like we do for diabetes mellitus. So that increase remission rate, there is less residual symptom, there is less recurrent stress, and there is less chances of TRD. But this is not at all advisable for the beginners, for the PGTs. You always start with single antidepressant as of now. Once you grow up as a big psychiatrist or a big expert in the field of psychiatry or affective disorders, you can have your own say. There are certain combinations which are called heroic combos. We all know this. The triple action combos of SSRI and NDRIs, which give single boost to all the 3 neurotransmitters of serotonin, norepinephrine, and dopamine. There is combination of SNRI with NDRI, like venlafaxine with bupropion, which gives single boost to serotonin, double boost to norepinephrine, and single boost to dopamine. This is another thing, California rocket fuel. We have been taught this since our PG days. Beautiful combination of venlafaxine and metazapine, which was also used as at the 4th phase of in the study trial. And so it causes quadruple boost of serotonin, quadruple boost to norepinephrine, and double boost to dopamine. So highly effective for TRD, but have the risk of causing serotonin syndrome. And this is another combo which is commonly used of SNRI and modafinil, which gives single boost to serotonin and norepinephrine, and as well as dopamine. So these combinations are most commonly used. Now, in case of treatment refractory depression, as the Maudsley guidelines suggest, we have as first choice the evidence is borrowed from study trial, and we have the second line agent. So we can either augment with bupropion or buspirone, or switch to venlafaxine, sertraline, or bupropion. All 3 are from different classes of antidepressant, and if they fail, we can add lithium or thyroid hormone, or switch to metazapine or nortriptyline. And if they fail, ultimately we have to use metazapine or venlafaxine, or we have to take recourse to tranylcypromine, which is now again have been marketed by a particular pharma company in India. And I have a limited experience in that molecule, and I find it to be very effective. Now, as a second choice, we have host of options starting from ketamine, esketamine, lamotrigine, SSRI, buspirone, which is a very, very effective combination, a high dose venlafaxine, ECT again, and thyroid hormone. These are all second line options, and we can use that. Also risperidone at low dosages. And these are the other options which have limited evidence, particularly in the form of open label trials or case report or case series. We can use amantadine, buprenorphine, cabergoline, cycloserine, and many other things, pindolol and whatnot. So we don't go to that extent. I think before that we invariably use ECT. So advances in new technology and emerging knowledge about the dysfunctional brain circuits underlying depression had led to the development of neuromodulation techniques, which are mostly non-invasive. We can use ECT, RTMS, as well as invasive techniques, VNS and DBS, with different safety profiles in our patients. For treatment-resistant depression, ECT and RTMS have level 1 evidence, whereas DBS, VNS, and MST have levels 2 and 3, 2 or 3 evidences. Now, RTMS, many of the higher educational centers or higher centers of psychiatry have RTMS machines nowadays. Here alternating current is passed through a coil placed on over the scalp near to dorsolateral prefrontal cortex, and that current induces a magnetic field which induces electric current in the underlying brain and cause neurons to fire. These dorsolateral prefrontal cortex has connection with ventromedial prefrontal cortex, which has connection to amygdala, and which ultimately fires the monoamine transmitter system in the brainstem. So the therapeutic effect similar to antidepressant takes place. There is a systematic review and meta-analysis of RTMS, where 23 RCTs compared RTMS with sham and 6 RCTs compared RTMS with ECT. The overall body of evidence favored ECT for treatment of patients who are treatment resistant, and repetitive TMS had a small short-term effect for improving depression, but the follow-up study did not show that the effect lasted for very long. Sorry. Yeah. DBS is almost akin to RTMS, but the difference is that no magnetic field is created here, and battery operated pulse generator is placed under the chest wall, and 1 or 2 electrode is tunneled inside the brain by neuroimaging guided, and it is guided by neuroimaging. Usually the electrode are placed near the subgenual part of the anterior cingulate cortex, which is a part of ventromedial prefrontal cortex, which has extensive connection to orbitofrontal cortex, amygdala, and brainstem monoamine neurotransmitter systems. When I searched for the literature for the neuromodulation in TRD, I came across this newer technique called Stanford Accelerated Intelligent Neuromodulation Therapy, which has been FDA approved for the treatment of TRD. There is one RCT in which 22 participants with treatment-resistant depression received, sorry, not RCT, open label trial. They received SAINT, and fMRI was used to individually target the region of the left dorsolateral prefrontal cortex, and which correlated with a subgenual anterior cingulate in each participant. 50 ITBAs of 1800 pulses per session, 50-minute intersession interval, were delivered as 10 daily sessions over 5 consecutive days at 9% resting motor threshold, and 19% met the criteria for remission, which is around 90.5%. So it is FDA approved now, but it is not available in India, as you all know. Although it is a presentation on psychopharmacology, I thought that the mention about the psychotherapy would be very adept, because psychotherapy has always been competition with psychopharmacology at the initial days of psychiatry, but ultimately it was elbowed out by the psychopharmacology. However, psychotherapy, like many other forms of learning, as well as many antidepressants, can hypothetically induce epigenetic changes in the brain circuits that can enhance the efficiency of information processing. The following psychotherapies are helpful in TRD, CBT, IPT, mindfulness-based CT, and trial-based therapy. One Cochrane review is available in the role of psychotherapy in TRD patients. It found that psychotherapy added to usual care is beneficial for depressive symptoms and for response and remission rate over short term for patients with TRD, and medium and long term effects seem similarly beneficial. So psychotherapy do act, although many proponents of biological psychiatry don't believe in psychotherapy per se, And available evidence indicates that failure to respond to pharmacotherapy in MDD is not a predictor of non-response to psychotherapy. So you can always use it. A Lancet study showed that subjects receiving CBT exhibited a significantly higher response rate at 6 months when compared to those in the usual care group. Atypical antipsychotics, it may increase response or remission rate in patients who have typically responded to more than 2 medication trial, even in the absence of psychotic symptoms. A meta-analysis by Wang et al. Showed, which included 11 randomized controlled trial, which included more than 3,000 participants, found superior efficacy to antidepressant monotherapy in TRD in terms of both response and remission. The effect size became larger as the degree of TRD was higher. So the more the difficult patient is to treat, the more effective are the atypical antipsychotics. This is another meta-analysis by Zhou et al. It included 18 RCTs of 7 different types and different doses of atypical antipsychotics and placebo. They found that all standard doses atypical antipsychotic for the adjunctive treatment of TRD are efficacious in reducing depressive symptoms. So this is very significant finding. All standard dose atypical antipsychotics apart from risperidone has significantly more side effect discontinuation than, and only quetiapine had significantly more all-cause discontinuation than placebo, and standard dose risperidone and standard dose aripiprazole were more beneficial than placebo, and standard dose risperidone was superior to quetiapine in terms of quality of life or function. So these are very significant findings from a very recent study. Aripiprazole, which we know as a partial antagonist at 5-HT1A, 2A, 2B, 6 and 7 receptors, and also has effect on serotonin transporter and alpha-1. It can be given at a dose of 2.5 to 5 milligram. We all know this. Brexpiprazole, it is also a partial agonist at 5-HT1A, D2 and D3 receptors. It is initiated at 0.5 to 1 milligram per day. It is not available in India, but will soon be available. Olanzapine, it can be used in combination with fluoxetine, which have potent 5-HT2A action compared to D2 receptor blockade, and initiated at a 625 milligram bedtime doses. Quetiapine extended release, again, it is very frequently used. It is also partial agonist at 5-HT1A receptors, and we all know the importance of 5-HT1A receptor in antidepressant response. I am suddenly showing you this slide, phenylcypromine. This is a non-selective and irreversible inhibitor of MAO. I didn't discuss in depth about the SSRI, SNRI, TCS, but I am showing this because this has again been revived by a particular pharmaceutical company, and it's found to be very effective for TRD, treatment-resistant social anxiety, treatment-resistant panic, atypical depression. There has been various myths about this MAO inhibitor, but Stahl Psychopharmacology beautifully repels those myths, and they list a few things that every clinician should know while before prescribing phenylcypromine. It has preferential action for MAO-B over MAO-A and increased availability of serotonin, dopamine, and norepinephrine. In TRD, after TCS and SSRI, TCP, phenylcypromine was found to be superior to placebo and non-established antidepressant, and was equal to other MAO inhibitors and an antidepressant combination. Lithium, we all know about lithium. It increases presynaptic formation, storage, and release of serotonin. It acts on phosphatidylinositol pathway. It has synergistic effect on mechanism of action and antidepressants. It reduces long-term risk of suicide. Similar efficacy in TRD compared to augmentation with SGA. No established blood level for efficacy in cases of TRD or RDD. It has been used at level 3 of STAR-D trial and resulted in remission of around 16% of the participants. Mean dose level was 0.6 milliequivalent per liter, and time to response was 7.4 weeks. T3, there is these are beneficial in absence of thyroid abnormalities. It causes desensitization of 5-HT1A inhibitory receptors. Thyroid hormone has been found to cause neuronal organization, neuronal arborization, and new synapse formation. Is also decreases the hypofrontality found in depressed patients. Meta-analysis showed augmentation may speed up responses to antidepressants. It was used in level 3 of STAR-D trial, which caused remission in around 25% of patients, and time to response was approximately 6 weeks, and mean dose was 45 mcg per day. Ketamine and esketamine, these are newer things, and ketamine is a non-competitive NMDA antagonist. The nasal spray formulation of esketamine, the S-enantiomer of ketamine, has been recently approved by FDA and European medical agencies as augmentation treatment in TRD. So how ketamine and esketamine works? It causes glutamine release from the nerve endings, and by simultaneously blocking the NMDA receptor and activating the AMPA receptor, it causes signal transduction of the ERK-AKT pathway, which again induces the mammalian target of rapamycin, and which ultimately result in the synthesis of proteins, which causes expression of dendritic spines, and which explains its early onset of antidepressant action. There have been contrasting results regarding ketamine and esketamine. Fava et al. Demonstrated that slightly higher doses of IV ketamine were better than placebo, and 2 double-blind RCTs regarding the efficacy of esketamine in the short term and 1 regarding time to relapse in the long term supported its approval from FDA in cases of TRD. So I will just go through these slides very rapidly. This is the French 2019 guideline, which gives some recommendations for switching of antidepressants. These are the recommended therapy for treatment potentiation: lithium, quetiapine, aripiprazole, lamotrigine, all I have talked about. These are the recommendations either in monotherapy or in combination for clinical dimensions of major depressive disorder. Like in case of anhedonia, we can choose an SNRI or SSRI, and we can combine it with alpha-2 antagonist. For cases of psychomotor retardation, again a TC, SSRI or SNRI. We all know this, but it is always to have a look at these things. This is the schematic overview of 5 antidepressant algorithms, not necessarily for TRD, but for depression, but it gives an idea what to follow, and if a particular antidepressant fail, what to do next. This is the last guideline by Canadian Network for Mood and Anxiety Treatment, published in 2016. So the first line evidence with level 1 evidence in literature, followed by second line and third line antidepressants. In case you switch, in case you augment, these are the first line option: aripiprazole, quetiapine, and risperidone, followed by brexpiprazole, bupropion, lithium, metazapine, and so on and so forth. Now, this has been a very, very good study from the Danish Register, published in JAD in 2021, in which they have seen patients for almost 20 years, and they had a huge number, recruited a huge number of patients, almost 2 lakh patients. So it gives an impression what to use in people with TRD. You can see that subpopulation of patients with TRD. If first treatment failed, then what to use next, and if that treatment also fails, then what would be the third treatment, what would be the fourth treatment, what would be the fifth treatment. It is a very beautiful article. You can refer to JAD. I won't go into the details of this study. This is another interesting study which I came across. This is a real world practice, and this study is from Asia. This study, it included around 250 practitioners from Japan, mainland China, Hong Kong, Taiwan, and it found that polytherapy is the thing which clinicians do when they come across TRD patients. Almost 71% practitioners use polytherapy, compared to around 28% who used monotherapy. And among polytherapy, antidepressant plus antipsychotic, which was the treatment of choice. Regarding approach to adjunctive antidepressant treatment in TRD, again, antipsychotics outnumbered ECTs, and ranking among TRD treatment approaches, switch to another antidepressant was the most commonly practiced approach when managing TRD. Now, it also found that around 76% clinicians were aware about TRD treatment guidelines, and most common guideline they followed was the APA guideline. So at the end, I again give you the algorithm for treating resistant depression. This is again a copycat of the study trial, but that is what we follow in our day-to-day clinical practice. And with this, I would like to end my presentation. Thank you all. Thank you for patient hearing.
Thank you so much, Kaustav. Yeah, I think that was a wonderful talk covering the entire field of TRD quite well. My compliments for that. Now, may I request my co-chair, Dr. Smita Deshpande, to kindly introduce our expert commentator, Dr. Supriya Hegde.
Thank you, Sudhir. I was deeply impressed with Kaustub's presentation and the depth that he has gone to for imparting this knowledge to us in this group. And it was interesting to find out that although the popular, what shall I say, thought for TRD was immediately to shift to something else, augmentation was probably a better strategy. So just as Avid Chakravarti here writes, there's a big applause for Kaustub. Kaustub, there are also several questions for you, which we will take up at the end of the commentary. So I'd now like to introduce to you our expert commentator, Dr. Supriya Hegde Arur. She is the professor and HOD psychiatry at Father Muller Medical College in Mangaluru, and she also practices as a consultant psychiatrist. She is an alumnus of KMC Manipal. In fact, a gold medalist there and has won several awards. DS Raju Award for the best paper in 2003, SS Jairam Award in 2012, and a Lady Lion Award for Health in 2021. And that shows her commitment to public service. She's especially interested in child and adolescent psychiatry and women mental health, as well as in stress management. So over to you, Supriya, for your comments.
Thank you, Dr. Smita. I would also like to thank Dr. UC Garg, my friend, Dr. Ruksheda Sayeda, Dr. Sudhir Bhave. I can see Sir Dr. Gautam Saha also. So it was, all of us will agree that Dr. Kaustav Chakravarti did more than justice to the presentation. I had seen his slides a day in advance, and he has covered the topic exhaustively. So as an expert, there is not much for me to do because Sir has done such a fantastic job. But in practice, I will just put in my thoughts in a few words. Refractory depression is a challenging clinical entity for all of us. In fact, it is a nightmare for a clinician because we have patients, struggling with symptoms, which when they become very severe and distressing and can result in suicide. So whenever there is a patient who does not respond for the first 6 to 8 weeks with an adequate trial of antidepressant, it makes the clinician very uncomfortable. But what we know is whenever we are faced with such a clinical challenge, the first thing that we need to know is, have I diagnosed correctly? That is the first dictum to see whether we are missing out a personality disorder, whether we are missing out on organicity, whether we have missed a comorbid untreated medical condition like hypothyroidism or uncontrolled diabetes mellitus. Sometimes it can be very simple. Then the second question that comes is there a substance abuse issue which we have not looked into? Because sometimes patients will try and minimize it or deny it altogether, and that really comes in the way of treating their depression. Another important question is compliance. Many times we assume that our patients are taking the medications, but surprisingly enough, there's so many of them who don't take their medicines regularly. So all these factors come into play when we are encountering a patient who's not responding to our medicines, who is treatment refractory, who is treatment resistant. In my clinical practice, and in the medical college also, when we encounter such a patient, we usually we go by the textbooks. We either change the class of drugs. First, we optimize the medication. Sometimes we are giving suboptimal doses, so we optimize the medication. Sometimes we augment. T3 is not available freely, so we are we usually augment with the lithium, and we try and reach a serum level of 0.6 to 0.8 milliequivalents and see whether that helps. In terms of the treatment guidelines, and as if we look at the STAR-D recommendations, certain rational pharmacotherapeutic combinations also work. If you want to stick with monotherapy, what I have seen is even the SNRIs work very well. So if you look at venlafaxine and desvenlafaxine and increase the dosage of them to the optimal, even those work very well. Another underutilized treatment for treatment refractory depression is ECT. I am a strong proponent of ECT. Even currently, we have a treatment-resistant bipolar depression in the ward, who's, in spite of lithium, in spite of a full dose of escitalopram, has gone into catatonia. And after the first dose of ECT, he is at least eating his food. So sometimes, we underutilize electroconvulsive therapy, but electroconvulsive therapy is excellent in a treatment refractory patient who's suicidal, who's vegetative, who's refusing food, who's catatonic. It works wonders. So to summarize, treatment refractory depression is a challenge. It's a clinical nightmare, in fact. Many a times, we end up taking multiple opinions, and patients run from one psychiatrist to another finding answer to this question. It is important to psychoeducate. That is one thing which I always feel, that many a times a lot of things are running in our head, but we do not tell the family members what we are doing. Especially with the educated class, it's important to let them know our stream of thought. We are trying to minimize unnecessary medicines. We are trying to optimize the drugs that we are already familiar with. We are trying to add on things which will not become like a cocktail regimen for the patient. And we are also willing to try other biological therapies like ECT to help our patient. So whatever said and done, a good 20 to 30% of all our patients will be treatment refractory. And it takes sometimes even, the only thing that comes to rescue is natural remission. So I've had to, sometimes I will, wonder whether I did something or it was God. So with these few words, I would like to end my expert comments. And Dr. Kaustav, very excellent presentation. I'm sure the postgraduates really learned from it. And very good, very great slides, actually. Thank you, sir.
So thank you, Supriya. And shall we now go on to the questions, Ruxida?
Yes, ma'am. Entirely up to the chairs.
So the first question had, in fact, come in while Kaustav was speaking, and that listener wanted to know whether, what was the place of vortioxetine and cariprazine in treatment refractory depression. So perhaps we can begin with that. And Subodh, maybe you can take up the next question.
Yeah, vortioxetine and cariprazine, we all know they have antidepressant action, and cariprazine even to some extent have action in cases of patient who are presenting with psychotic symptoms, and they all have neurotransmitter actions which are favorable for a depressive patient. But their role in TRD is yet not verified or has not been established in literature, scientific literature. So when we talk about evidence-based medicine, in probably next 5 or 10 years, they will their name will be there in the list of options as a second line or third line agent. But as of now, what I have presented in my slides is the available evidence as we are talking in year 2022, and they are the last things that we are going to add if a patient is not responding to the usual therapies. And as I want to emphasize once again, that ECT is very much underutilized these days, particularly modified ECT. Particularly in state of West Bengal. I don't know about other states. In PGI, we used ECT a lot, and it worked wonder. I had treatment-resistant depression as my MD long case. So I had tremendous difficulty in managing that case, and ultimately We had to give maintenance ECT, and she remained well with that. So before we go to cariprazine or vortioxetine, we have ECT as an option. That is my final comment.
Thank you.
Thanks a lot. Kaustubh, there's I think, a very important question. Can you please throw some light on bipolar depression? I think that's clinically very important because we know that many of the resistant depressions could in fact be bipolar depressions. So how would you go about treating such a case?
Yeah, actually, first it is imperative to recognize whether the patient is having bipolar depression or not. So that means whether the patient is having a bipolar disorder or not. So what we frequently miss our clinical practice is whether patient had a manic or hypomanic episode. We don't miss manic episode that much, but we often miss a hypomanic episode in our clinical practice because those are perceived as days of good functioning by the family members. So we need to be careful while taking a history. We can apply mood disorder questionnaire if we are not sure, very sure. And once we are certain that patient is having a bipolar disorder with past history of hypomanic episodes somewhere 5 or 10 or 15 years ago, and is now presenting with a recurrent depressive episode and indexed episode is of depression with psychotic symptom or severe depressive episode. So we can always, as per the classical teaching, can go with lithium if there is no thyroid abnormality, and as the evidence base goes, I would like to go with lamotrigine if patient tolerates it well, because there are meta-analysis in favor of lamotrigine, there are meta-analysis in favor of quetiapine. So as a conservative person, I would go with a combination of lithium with lamotrigine or lithium with quetiapine, or 3 together at the same time. And they work well in a case patient of bipolar depression. But having said that, bipolar depression is always difficult to treat. They tend to persist for a long time, and they tend to respond poorly to the SSRI or SNRIs. But as a desperate measure, you need to add SSRI or SNRI in some cases with a caution to switch to manic episodes, and you need to educate the family members that if they see such symptoms, they need to inform you very at the right time. Thank you.
Yeah, thank you, Kaustubh. And there's one other very insightful question. What happens if cognitive symptoms still persist, although the mood symptoms have disappeared?
Just a minute. Yeah. I would like to give you inputs as senior persons also, so I can learn from you also. So a bit from you. Word of wisdom.
Okay.
Regarding that bipolar depression.
Okay. No, I agree with you that the bipolar depression is a very tough call to treat. But one is always scared as to what will happen if the person slips into mania. Because very often the family has a bigger problem with manic symptoms. They are more scared, they are more frightened because of the patient's excitement. So in some ways, the family is sort of more comfortable if the person is not excitable, angry, irritable, and so on. So it's always like an acrobatic feat to keep the patient at a euthymic level, or at least, not in a hypomanic or a manic level. And as you described, mood stabilizers are a very good way of tackling the problem of difficult bipolar depression.
Right. I would just like to add here, Kaustubh, that I think one important point is that even if there has been no history of hypomania or mania, there are some pointers to the fact that this could be bipolar depression where mania has not yet become obvious. I mean, no episode of mania, yes. I mean, the family history of bipolarity, early onset, more severe symptoms, a briefer course, non-response to antidepressants. So I think if based on these pointers, if we have a doubt of maybe
even postpartum depression also.
Yeah, we can only say maybe bipolar because the hypomania or mania has not become evident so far. So I think there also perhaps the strategy for bipolar depression could be used instead of strategy for unipolar depression.
Okay, so Kaustubh, let's go
Yes.
back to the original question
Yeah.
of what happens if the cognitive symptoms persist. And there was also another additional question, is whether there was any role of vitamins in the treatment of TRD.
Yeah. Like if cognitive symptom persist, that also contributes to recurrence of depression and decreased functionality and increased burden in cases of patients with TRD. Regarding treatment of cognitive dysfunction, we need to select agents with increases the prefrontal cortex dopamine levels, and there are certain agents which do that actually. So we need to combine rationally. Like I talked in my presentations, there are multiple combinations which can increase the prefrontal cortex dopamine levels, not to the extent that amphetamines do, but there are agents. And along with that, we can go for cognitive retraining, the cognitive behavior therapy, the mindfulness-based CTs. Those are very much effective in improving cognitive symptoms. But if the cognitive function is impaired due to some physical problems, like some brain insults or some old aged small vessel disease of brain, it is very difficult to improve with medications. In that cases, physiotherapy and other psychotherapies do help to some extent, but the patient will never get full remission. And the thing regarding vitamins, there is not much evidence, but what I can tell about that is there are some evidence regarding SAMe, S-adenosylmethionine and tetrahydrofolate. Those are the methyl donors, and methyl donors, apart from being helping the production of cofactor tetrahydrobiopterin, which is essential in the path rate limiting for the working of the rate limiting enzymes of tyrosine hydroxylase and tryptophan hydroxylase. They have also have a role in silencing certain genes like COMB gene, which is used for breakdown of monoamine neurotransmitters. So they can donate their methyl group for silencing of those genes, and has been found to be effective in depression. SAMe again it is broken down to methionine and ultimately methionine but excessive use of those agents have been found to raise homocysteine level, which again can be detrimental to health. So we have to be careful. If people are deficient in those things like folate and methionine levels, so they only in those patients we can use these agents, not otherwise.
Okay, so last question, because I can see that Ruxida is waiting to wind up.
Ma'am, it's entirely up to you. We'll continue. We'll carry on. Please answer all the questions.
No, Dr. Garg has also put in an observation that ECT is underused, and I agree with that. That ECT is definitely underused today, and with the MHCA and the other problems with the ECT, it will, I'm afraid, continue to be underused, and therefore it's important for us to find some equally good alternative to ECT rather than wade through all the legal difficulties that we need to go through before we can use ECT for any patients. There was one okay, so this is not a question, are the use of nutraceuticals overhyped? But please do answer if anybody has mentioned pramipexole for TRD, because that's something that has come up in the questions. And at one point of time, I do remember that it was being touted as the drug for treatment-resistant depression.
Madam, yeah, I have used pramipexole in some of my patients and found to be
so have I. Yeah,
found to be effective because it is very difficult to say whether it is efficacious or not in real world practice, but I have found it to be effective, and theoretically it has the reason to be effective in treatment resistant depression because these all are dopaminergic agents, and if they are improving Parkinsonism, so they will also improve depression to some extent because of the rising dopamine levels in prefrontal cortex as well as other areas of brain. Yeah, they have a role. There is no doubt in that. Rasaziline, again, another anti-Parkinsonian agent that can also be used in treatment-resistant depression. But I have highlighted only the most commonly used strategies and most commonly used molecules. There are many, like I have shown you the Maudsley guideline, the list of other options. There are anything and everything, probably starting from pindolol, minocycline, anti-inflammatory agents, even paracetamol. If you take it, improves mood for few hours or something. So there are anti-inflammatory hypotheses, and there are n number of hypotheses for depression. But whether those are mostly peripheral or they affects the brain, and whether they can sustain the remission is still very much debatable. But definitely, the anti-inflammatory molecules and neuromodulatory agents do have a role, and in future, in next 10 to 15 years, they can be proven effective in treating depression. Yeah, that's it.
Yes. So what our audience needs to remember is what you have presented is whatever is available as an evidence. And of course, in the clinic, we can always use, based on our clinical experience and whatever, in a one particular case, what will work and what will not is difficult to say. But that may not go according to the whatever the guidelines are. So I'd like to now hand over to Rukseda to conclude the session, because now the questions that are coming in are little peripheral.
Just one comment before. This is for the PGTs actually. In my clinical practice, I do see the dose of venlafaxine is around kept at 75-150 milligram. I would like to request the PGTs to use venlafaxine at a dose of 225 or 300 milligram if the patient's condition permits. Because underutilizing the dose of venlafaxine or underprescribing venlafaxine is not going to help the patient when you are confronted with treatment-resistant depression or poor response from a particular patient. Venlafaxine is a very good molecule in my clinical practice, and there are again I would like to raise a certain fact that there are a group of patients who responds to venlafaxine but who do not respond to desvenlafaxine, although they have similar mechanism of action. The one plausible explanation might be that venlafaxine gets converted to desvenlafaxine in the body by cytochrome 2D6 enzyme, and patients who have polymorphism in those enzymes might not be able to convert to desvenlafaxine in the body. So that might be one reason why desvenlafaxine may not act for certain group of people, but venlafaxine acts in them. I don't know. That may be a possible reason. But do use venlafaxine in proper dose and higher doses. That is the message I want.
No, I would say, Kaustuv, I'll add to that do use all antidepressants in a proper dose with an informed method of talking to your patients, convincing them to take the medication, and at every visit try and make sure about the adherence.
Yes.
Invite the person's cooperation, the patient's partnership, the family's partnership and involvement, because otherwise if adequate doses are prescribed but not taken, things will not work.
Sure.
I'll hand over now to Rukseda.
Yeah, just a minute. I mean, before it goes to Rukseda.
Sudhir, sorry. Please continue.
Okay. I was just thinking of one thing, that when you talked of vitamins, you did not talk about vitamin B12. Means, is that not important? Like in India, the B12 deficiency is very common, and its association with depression is known to be fairly robust. So, any comments on that?
Yeah, sir. Again, I am saying that methylcobalamin, what methylcobalamin do that, it is a methyl donor actually. And the methyl group donor is definitely important for the working of the cofactor tetrahydrobiopterin, which is again is involved in the pathway of synthesis of serotonin, dopamine, and norepinephrine. And if that is deficient in our body, then definitely vitamin B12 is warranted for the treatment of poor responder or non-responder or in treatment-resistant patients. But without that, vitamin B12 as such has no role. Those who are deficient, it has definitely some role.
Right. So over to Rukseda.
Thank you so much, sir. Supriya, any last comment?
Oh, Shweta, nothing. Thank you.
Great. Thank you so much. Thank you so much, everybody who joined in. We hit our average audience today as well, so that's great. I would like to inform everybody that IABP has a dedicated YouTube channel. Please, all our sessions, CME sessions are available. It's an open access. Please like, share, subscribe to the channel so that it encourages us to give more biological data and improve our content as well. I had shared the link on the chat earlier, but please feel free to message me for the link as well. And when we upload this particular CME series in the next few days, we are sure to share that link again with everybody, because also the slides have been, really appreciated across everybody. So please feel free to harass Dr. Chakrabarty for them. At this point, may I please invite my very able Joint Secretary, Dr. Abdul Majid from Srinagar, to give us a word of thanks.
Thank you, Dr. Rukhsheda. It's always a pleasure to be part of the presentation where you learn. And in fact, one of the best teachers, I would say, in Indian psychiatry, Dr. Kaustov Chakrabarty, a dear friend from Kolkata. He has been more of a teacher today, teaching all PG trainees, including me. So thank you very much for a wonderful session. And Dr. Sudhir Bhave, he's an elder brother. He has shared it so nicely, along with the very experienced, very talented Madam Dr. Samita Deshpande, and the person who, with expert comments from her experience from the medical college and as a practicing psychiatrist, was Dr. Supriya Hegde. So all of it was a team effort, I think, and it was a very nice academic feast. We really miss these feasts. We used to have them during the conferences. Now conferences are a rarity now these days, but still, thank you IABP, and thank you all office bearers, including the president, Dr. UC Garg, and Dr. Rukhsheda, for making this evening possible. And we are sure every one of the people who were on the panel would have enjoyed the academic feast. And we are sure that next time we are meeting again is next month, next Friday, the first Friday CME to be held by IABP. Thank you all. Thank you, speakers, chairpersons, and most importantly, the participants who asked questions. And some of them did not ask questions, but definitely might have learned a lot from the presentation. Thank you all again. And it's over to the back staff who are managing it. Thank you very much.
Thank you so much. I would like to inform everybody that Alchem Laboratories has extended an unrestricted educational grant for this particular CME series today. And with that, we wish you everybody health and happiness, and a very good evening to everybody. Goodbye.
Goodbye. Bye. Bye-bye.